I think the very most kind of high level understanding of this is currently when a patient walks into a clinic, a breast cancer patient, she finds what the biomarkers they look at are what is your ER level, your PR level, so are you hormone receptor positive, and what is your HER2 status? Are you HER2 positive or not? And then treatment is based on that. And I think we are now at a point where that is no longer adequate and it's no longer necessary to have that paucity of biology captured, because with our much wider range of options for treatments, we need to bring in additional biology, and having a really solid immune predictor in each subtype of breast cancer, and actually overall across cancer types, is super important now that this has become a major player in the landscape. And we're getting a better appreciation of what these immune-related toxicities are. And so we need information on probability of response for each patient, and including in triple negatives, because right now it's standard of care. But if you have a patient who maybe already has a history of colitis or has some thyroid dysfunction, and who's really nervous about aggravating her already sensitive kind of autoimmune, sort of a milieu, she and her doctors together may decide that, yes, I'm willing to take the risk of having that immunotherapy if my response rate is likely to be, greater than 60, 70, 80%. But if it's going to be lower than 50%, I think I'm going to skip the immune drug, and instead I'm going to just go with the standard, and I'll add carboplatin, because that difference in response was only about 10%. So that's why I see it being important, and we're all part of an evolving system, and I fully expect that in the next 5 years, I don't know whether it'll be this immune biomarker or some other immune biomarker. There's probably going to be a bunch flooding the market, but at the very least, every HER2 negative patient who comes into the clinic is going to be assessed for HR, for HER2, and for immune, and that immune biomarker will not be PD-L1 because it doesn't work.